Hey guys, welcome to Medifaction. Today we're going to learn about the trachea. Trachea in general is a windpipe, which is the patent tube for passage of air to and from the lungs. So here you can see a rough figure of trachea. So today we can have a deeper look into the trachea. So in this video, we are going to enumerate the introduction about trachea, relations of trachea with the thoracic part, the structure of trachea, the blood supply, that is the arterial supply and venous drainage of trachea, the lymphatic drainage of trachea and nerve supply, as well as we are going to also discuss about the histology and some of the clinical anatomy of trachea. Introduction. The trachea is a wide tube lying more or less in the midline, in the lower part of the neck and in the superior mediastinum. Its upper end is continuous with the lower end of the larynx. The trachea in the neck is covered by the isthmus of the thyroid gland and acts as a shield for trachea. At its lower end, the trachea ends by dividing into the right and left principal bronchi. The trachea is 10 to 15 cm in length. Its external diameter measures about 2 cm in males and about 1.5 cm in females. Lumen is about 3 mm at 1 year of age. During childhood, it corresponds to the age in years with a maximum of about 12 mm in adults. That is, it increases 1 mm per year to 12 years. The upper end of the trachea lies at the lower border of the cricoid cartilage. Here you can see the cricoid cartilage opposite the sixth cervical vertebra. In the erect posture, the bifurcation lies at the lower border of the sixth thoracic vertebra and descends still further during inspiration. Over most of its length, the trachea lies in the median plane, but near the lower end it deviates slightly to the right. As it runs downwards, the trachea passes slightly backwards following the curvature. So this is the tracheal bifurcation I was talking about, and this is the trachea. Relations of trachea with the thoracic part. Anteriorly, we can appreciate the manubrium sterni, sternothyroid muscles, remains of the thymus gland, left brachiocephalic and inferior thyroid veins, aortic arch. Here you can see the aortic arch, and also brachiocephalic and left common carotid arteries, deep cardiac plexus, some lymph nodes also in the anterior aspect. Posteriorly, we can observe the esophagus, the vertebral column. On the right side, right lung and pleura, right vagus, and also esophagus vein. Here you can see the vagus nerve, which is the 10th cranial nerve, and the esophagus vein. On the left, we can observe here the arch of aorta, the left common carotid and left subclavian arteries. Left recurrent laryngeal nerve can also be observed. This is the recurrent laryngeal nerve. Structure of trachea. The trachea has a fibroelastic wall supported by a cartilaginous skeleton formed by C-shaped rings. The rings are about 16 to 20 in number and make the tube convex anterolaterally. Posteriorly, there is a gap which is closed by a fibroelastic membrane and contains transversely arranged smooth muscles known as the trachealis. Here you can find out the trachealis. The lumen is lined by ciliated columnar epithelium and contains many mucous and serous glands as well. Moving on to the blood supply. For arterial supply, inferior thyroid arteries plays the major role. Here you can see the inferior thyroid artery, and for the venous drainage, it drains into the left brachiocephalic vein. This is the left brachiocephalic vein. Coming to the lymphatic drainage, it drains into the pretracheal and paratracheal nodes. You can appreciate the pretracheal and paratracheal nodes right here. Moving on to the nerve supply. In the parasympathetic innervation, nerves through vagus and recurrent laryngeal nerve, it is sensory and secretomotor to the mucous membrane and motor to the trachealis muscle. Here you can see the left recurrent laryngeal nerve, and also for the sympathetic innervation, fibers from the middle cervical ganglion reach it along the inferior thyroid arteries and are vasomotor. Now let's move on to the histology of trachea. Trachea is a thin-walled flexible tube. The trachea is lined by pseudostratified ciliated columnar epithelium with interspersed goblet cells resting on a basement membrane. Here you can see that, and these are the goblet cells which I told was resting on the basement membrane. The lamina propria right here consists of elastic fibers, lymphocytes, both segregated and aggregated, and short ducts of glands. The submucosa, which contains both mucus and serous acini that keeps the epithelium moist. The most characteristic feature of trachea is its supporting framework of 16 to 20 C-shaped hyaline cartilages that encircle it on its ventral and lateral aspect. Here you can see the hyaline cartilages, and these are the chondrocytes. The cartilage is covered by perichondrium on all sides, which separates it from the neighboring structures. The outermost layer is the adventitia, which contains blood vessels and nerves. Now moving on to some of the clinical anatomy of trachea. In radiographs, the trachea is seen as a vertical translucent shadow due to the contained air in the front of the cervicothoracic spine. Clinically, the trachea is palpated in the suprasternal notch. Normally, it is median in position. Shift of the trachea to any side indicates a mediastinal shift. During swallowing, when the larynx is elevated, the trachea elongates by stretching because the tracheal bifurcation is not permitted to move by the aortic arch. Any downward pull due to the sudden or forced inspiration or aortic aneurysm will produce the physical sign known as tracheal tug. Tracheostomy is a surgical procedure which allows air to enter directly into the trachea. You can see that here how it looks like. It is done in cases of blockage of air pathway in nose or larynx. As the tracheal rings are incomplete posteriorly, the esophagus can dilate during swallowing because esophagus are seen on the posterior aspect of trachea. This also allows the diameter of the trachea to be controlled by the trachealis muscle. Trachealis muscle narrows the caliber of the tube, compressing the contained air in the vocal cords are closed. This increases the explosive force of the blast of compressed air as occurs in coughing and sneezing. Mucus secretions help in trapping inhaled foreign particles, and the soiled mucus is then expelled by coughing. The cilia of the mucous membrane beat upwards, pushing the mucus downwards the pharynx. The trachea may get compressed by pathological enlargements of the thyroid, the thymus, lymph nodes, and the aortic arch. This causes dyspnea, that is, shortness in breath, or irritative cough, and often a husky voice. Hope you have understood the video. Like, subscribe, and press the bell button for more videos. Thank you. Thanks for watching.